Good evening, everyone. Welcome. My name is Siti. It is my pleasure to welcome you to SACB's 20th module of the education program supported by SACB. Today is our 7th lecture of the 10 series program. And before I introduce the speaker for today, let me flash the housekeeping items. The lecture will commence at 6:30, and at the end of the session, there'll be a short Q&A session. So during the presentation, you can actually start putting in the questions as well. So you can type in your questions under questions. And the materials for today's lecture is already available under handouts. So again, to remind everyone that certificates will be issued at the end of 10 lectures, and also to attain at least a minimum attendance of 80%. And all the lecture materials will be available for 1 month post each session. So without further ado, let me introduce our speaker for today. He's a familiar face for today's session. You've seen him for the past 6 weeks, and today he'll be the one presenting instead of hosting. And Dr. Tan Jun Guan is a registrar from Khoo Teck Puat Hospital, and he has special interest in biochemistry. Today, Dr. Tan will be presenting on calculated values in clinical chemistry. So, Dr. Tan, it is a pleasure to hand over to you.
Thank you, Siti, for the kind introduction. Okay, so can see my screen? Okay, so thank you so much. Okay, so I shall just need to do laser pointer and pen. Okay, so thank you for taking the time off your busy schedule to attend today's lecture. Today, my topic is calculated laboratory values. So we are going to go through what are calculated laboratory values, some of the calculated laboratory values, red cell indices in hematology, such as hematocrit, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration, and then some of the considerations in clinical chemistry. Of note, we'll go through calculated LDL cholesterol, calculated osmolality, calculated albumin-adjusted calcium, and estimated glomerular filtration rate. We also talk about some of the new developments that's actually happening over the past 1 month on estimated glomerular filtration rate. So what are calculated laboratory values? So results can either be we measure it directly or we can don't measure it. We use other results to derive a calculated values based on some physiological relationship and some definitions. So we can have a quick poll of what is the parameters are calculated. Okay, yep, I think we can try to see the results of the poll. Actually, how do I see the results of the poll?
Oh, it should be on your screen, Dr. Tan.
Oh, okay.
So about 46% answered MCHC, followed by 18% for hematocrit and hemoglobin.
I see. So okay, so yeah, so I guess most of you are correct. Okay, so in fact, actually a lot of calculations are actually calculated. So we have a few key core equations in the red cells indices, which will be explained in the next few slides. So as you have guessed correctly, MCH, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentrations are calculated. The measured analytes, usually hemoglobin concentration in the RBC count, are actually measured, and then whereas mean corpuscular volume or hematocrit depends on analyzer, it can either be measured or calculated. So we always see this is a bedrock of the equation, which is hemoglobin is equals to MCH, mean corpuscular hemoglobin, times RBC count. What does that mean? HB is just your hemoglobin concentration. MCH is the average amount of hemoglobin per red cell. So you have one red cell, you have this hemoglobin, you times the number of RBC per unit volume. So it will just give you the total hemoglobin concentration. So it's actually quite logical. So to find this MCH, you just need to rearrange. So as long as we can get some hemoglobin from analyzer and the red blood cell count from the hemolyzer, we can actually find our mean corpuscular hemoglobin. The second equation is hematocrit. It's given by, which is the volume occupied by RBC, is equals to MCV. MCV is actually mean corpuscular volume. Each red cell has one volume, and then times the number of RBC. So the volume of each red blood cell times the number of RBC you have give you the total volume occupied by the RBC. Okay, and then the third calculation is concentration. As you know, in high school, in secondary school, we learned that amount divided by volume gives you the concentration. So analogous to this, your mean corpuscular hemoglobin concentration, which is the concentration of hemoglobin in one RBC, is given by the average hemoglobin in one RBC over the volume of RBC. You may also see this equation, HB over HCT, but actually they are the same. So amount divided by volume. So in fact, what happens is that your amount is the hemoglobin divided by the volume occupied by the RBC. So what we can do is that this is exactly the same as this. So what we do is that on the upper side times the RBC count, lower side times the RBC count, as per just now, the equation in our slide 1 and slide 2, MCH times RBC count gives you HB, MCV times RBC count gives you HCT. So yeah, in general, it's just based on like some basic principles like of amount over volume, so we can get some of the indices. So in essence, as the red cell indices are shown, we don't really have to measure a value, but simply basing on some relationship, we can report a value. So of course, since I'm from biochemistry, so we are going to go through some biochemistry parameters today, which is calculated LDL cholesterol, calculated plasma and serum osmolality. So the plasma and serum osmolality, actually in laboratory, we don't really calculate. We measure it, but it can be useful to the clinician and also be useful to the technologies on the validation bench. Okay, and thirdly, we have this albumin adjusted calcium. You may have also call it corrected calcium if you are less dogmatic. So some more dogmatic people will insist on albumin adjusted calcium. And lastly, we will go through creatinine clearance and the estimated glomerular filtration rate. So firstly, what is LDL cholesterol? So why do you want to calculate LDL cholesterol? The most famous formula, Frederick formula, how do they derive it? So you have seen two reports. On the left is actually an electronic report. So both are my patients actually. So you see that there's this calculated LDL cholesterol. So this lab specifically mentioned that it's a calculated value. On the right, you see another report a few years ago. So see that LDL cholesterol, but it didn't tell you whether it's calculated or is it measured. So of course the unit is mg per deciliter. But if let's say we know the Frederick equation, we will understand that actually this LDL cholesterol, although the lab didn't mention it, it's actually calculated. So what is exactly the difference between calculated and measured? And is LDL the same as this LDL cholesterol? So quick revision of lipoprotein metabolism. So in our blood, actually cholesterol don't travel freely. What it happens is that it will package into a nice package. So this is called lipoprotein. Inside the lipoprotein core, there's actually this thing called cholesterol ester. And on the surface of this, you can see some free cholesterol. But generally, the free cholesterol do not travel freely around. So this lipoprotein also have apolipoprotein B, C, and E. So some people call it apolipoprotein or apoprotein. So depending on the type of lipoprotein, which is this particle. Okay, so lipoproteins, there are many types, at least 4 to 5 types. So we have the very big chylomicrons. We have the slightly smaller, the very low density lipoprotein. We have the very small one, low density lipoprotein, which inside this particle, if let's say you have a cholesterol, so inside this particle you have cholesterol. You have cholesterol. Okay, so it's the cholesterol that's inside this particle that is dangerous. That we call it the bad cholesterol. Okay, so you have a few of it. Sorry. Okay, so yeah, so there's also intermediate density lipoprotein which disappears very quickly. Put in another way, this is a very complicated slide, But what essentially we need to do is the liver produces this thing called very low density lipoprotein. And this very low density lipoprotein becomes this intermediate density lipoprotein, which becomes this low density lipoprotein. And this low density lipoprotein is the bad particle, which will cause a lot of arteriosclerosis. So why are we so interested in the cholesterol inside the low density lipoprotein? Because there's many studies, whether it be like randomized control trials, prospective cohort studies, Mendelian randomized studies, they have shown that the lower your LDL cholesterol, the better your cardiovascular health will be. So it has been proven in many studies. So therefore, we are interested in this LDL cholesterol because we want to improve our patients' health, cardiovascular health. So traditionally, many years ago, and actually this is the gold standard, so you can do an ultracentrifugation, okay, and then you can find this low density lipoprotein fraction inside it. Okay, so but this will require ultracentrifugation. So therefore, in those days whereby such complicated methods are not very available to the laboratory, so Freddy Bell in 1970s, what he understands is that he wanted to derive an equation. So just now we mentioned that cholesterol don't travel freely. Cholesterol must be traveled inside the chylomicron, must be traveled inside the VLDL, LDL or HDL. And so therefore, your total cholesterol in the blood must be equal to the chylomicron cholesterol plus the VLDL cholesterol plus LDL cholesterol plus HDL cholesterol. Okay, so but in a fasting state, let's say we ask our patient to fast for 6 to 8 hours or 10 hours or 12 hours, there should be no chylomicron because chylomicrons tend to occur immediately after a meal, after a fatty meal. So we can cancel away. We left with VLDL cholesterol, LDL cholesterol, and HDL cholesterol. So for this, well, what happens is that he found that most of the TG, right, triglycerides is carried within VLDL cholesterol, and the ratio of the VLDL cholesterol to TG is 2.2. So what he did is that he decided to sub VLDL cholesterol is equals to TG over 2.2. Okay, so he sub this equation inside. So you get total cholesterol equals to TG over 2.2 plus LDL cholesterol plus HDL cholesterol. So rearranging, this is our Freddy-Well formula, which Freddy-Well found in 1972, and 50 years later, we are still using it. So if you read the original paper, because America side, they use mg per deciliter. In SI units, where your TG is millimole per liter, your cholesterol is millimole per liter, you use 2.2. So what he found is that actually in normal people, his formula works very well. In type 2 lipoprotein disorder, type 2 lipoprotein disorder is this thing called familial hypercholesterolemia. It's a genetic condition whereby cholesterol is very high. So what happens is that it works very well in this kind of patients too. But then if you were to look at your LRS, you'll find that, or the lab reports, you'll find that occasionally, if let's say your TG is greater than 4.5 millimole, then your lab will report as, okay, TG greater than 4.5, unable to calculate LDL cholesterol. Why is this so? Because Freddy-Well in 1972 found that if in certain patients, if let's say their TG is greater than 4.5, okay, the behavior, the regression line doesn't work that well. So he has to remove it. So this is in type 4 lipoprotein disorder. Type 4 is actually people with a lot of VLDL. So you can see that TG less than 400 because they're using mg per deciliter units. Yeah, but generally, because of what he found 50 years ago, the TG greater than 4.5 millimole, the relationship doesn't work that well. So therefore, we follow him. And till now, let's say your TG is greater than 4.5, we are unable to report a calculated LDL cholesterol. But 50 years has since passed, 1972, and now it's 2021. So in the middle, is there any other equations? Yes, so you have a rather famous one, Martin Hawkins in 2013. You also have another Sampson's last year. So what is Martin Hawkins' equation all about? Essentially, it's almost the same, just that they have this novel factor. So instead of 2.2, they decide that actually your ratio of VLDL cholesterol to TG isn't always 2.2. 2.2. So okay, so what happens is that you can see over here. you can see over here that depending on the triglycerides, depending on your non-HDL cholesterol is just your total cholesterol minus your HDL cholesterol. You can have varying TG over VLDL cholesterol ratio. So imagine we have how do we use this table? So imagine we have a patient, okay, so with so maybe let's say it's a TG, okay, with maybe let's say 100, okay. I'm using the best unit, 100 mg per deciliter, and then you have a non-HDL cholesterol of maybe 200, okay, so 200. So we go and find. So this is our non-HDL cholesterol, and then this is our TG 100 will be somewhere here. So we do an intercept, okay. So we will substitute this 4.5 into this noble factor, and we can continue to calculate. Yeah, but the problem with this is that this is actually quite difficult for the LIS to implement, because you need to have if TG goes to 7 to 49 and non-HDL cholesterol less than 100. If this is 7 to 49 less than 100 to 139, so you need to have 180 permutations. So it's pretty difficult for some of the LIS to calculate. So moving to the next one, which is called the Sampson equation 2020. So this was developed last year. They based on quite old data, so 1976 to 1999. And the reference method was the data quantification reference method, which is the ultracentrifugation one. And they found out with this formula. So apparently, what the authors mentioned that is supposed to correlate with the LDL direct measurement better. So what formula does your lab use? Okay, so actually in Singapore, for at least for the public labs, those are using calculator will tend to use Frediswell because it has been tried and tested for 50 years. Martin-Hawkins will be a bit difficult because of the LIS limitation. Sampson, because it just came out last year, so I think most labs haven't implemented it. And according to Dr. Liu Xingde 2 weeks ago, we have this HSA EQA. More and more labs in Singapore are actually participating in the direct measurement of LDL cholesterol. So more and more labs are shifting from calculation to direct measurement instead. So what are the limitations of calculated LDL cholesterol? So number one is that you have to reject samples greater than 4.5 millimole. Therefore, you might need to have fasting. You also need to measure three other analytes, which is your total cholesterol, your HDL cholesterol, and your TG. So therefore, what happens is that imprecision of these three analytes will contribute to your imprecision of your calculation. So therefore, your imprecision of LDL cholesterol calculated actually will be higher. It might also be more expensive than one single LDL cholesterol. So for example, certain clinicians like the cardiologists, they may just be interested in the LDL cholesterol. They may not necessarily need the triglycerides, the total cholesterol, or the HDL cholesterol. So in that case, just offering one single measurement for LDL cholesterol might actually be sort of cheaper. So depending on your laboratory, let's say your laboratory is measuring direct LDL cholesterol, you can actually play with some of the equations. So this is my lab, and we found that actually Frediswell, the performance tends to be lower than the measured. So Frediswell seems to underestimate a bit. So what we found is that actually Sampson equation, the one that was published last year, actually has the most accurate, because probably because it's 2020 and now today is 2021, whereas Frediswell is 1972. So in general, this is the formula. Generally reliable as long as there's no remnants or there's no chylomicrons and your TG is less than 4.5. At very high concentration of TG, this factor doesn't work very well, and then you end up underestimating your LDL cholesterols. There are also other formulas, but because they have been recently published, so not commonly used. Public labs wise, most of the LDL cholesterol seems to be calculated. Okay, so we'll go through our second part, which is calculated osmolality. In the lab, we usually do not calculate osmolality. We measure it using freezing point depression, but it's useful, may be useful to medical technologists to when at the validation bench. So we are going to go through why is it useful to the clinician as well. So what is osmolality? So in general, osmolality is a measure of dissociated solutes in a solution. So let's say you have 1 kg of water, you put 100 millimole of sodium, 150 millimole of chloride inside. So complete dissociation should be 150 plus 150 give you 300. Okay, so some labs uses millimole per kg as unit, some labs uses milli-OSM per kg as unit. So what is this idea of calculated osmolality? So in plasma, we have the cations, mainly sodium, some potassium, some calcium, some magnesium. You have the anions, some chloride, some bicarbonate. We have neutral, such as glucose and urea. So if the ions completely dissociate or the neutral molecules completely dissolve, the sum of their concentration will equals to the osmolality. So the calculated osmolality is equals to all your positive ions plus negative ions plus neutral. So because you know electrical neutrality, so positive ions and negative ions should be about the same. So 2 times positive ion. The neutral is mainly glucose plus urea. So we can have 2 times Na plus glucose plus urea. So because most of your positive ions is actually fall under this sodium. Okay, so in ordinary circumstances, your calculated osmolality, which just now we have shown you how to derive, is 2 times sodium plus glucose plus urea, should be equals to or about the same as the measured osmolality from your freezing point depression method. So the difference should be small, so usually less than 10. So however, some less than 5% of the time, actually there can be a big difference. Usually it's less than 10, but sometimes it can be more than 10. So why is more than 10? So yeah, one of the reasons is actually this ethanol or ethylene glycol poisoning. Okay, so the clinicians upstairs, I mean, if your lab is in the basement, the clinicians upstairs will calculate osmolality and osmolar gap when they suspect certain things. Okay, so ethanol, ethylene glycol, we are in Singapore, it's along the equator, whole year summer, so less of this antifreeze, but in the UK, in Australia, in US, Europe, it's more common as a method of attempted suicide. So osmolar gap is given by measured OSM minus calculated OSM, which will be greater than 10 if let's say you have these two substances inside. So the rationale is because when we calculate OSM, we don't calculate the antifreeze, we don't calculate the ethanol. So our calculated value will miss out both, whereas your measured value on the freezing point depression will be able to capture both. So therefore, there is a gap. Okay, so we can go to one of these questions. So okay, so this is if you take a look at 2 times sodium plus urea plus glucose. So 2 times sodium is 136. Then your urea is 1.8. Our glucose is 6.4. So it's 280. Okay, but our osmolality measure is 395. So 395 minus 280 is 115. So there's a very big gap. So what happens to this very big gap? So is it our instrument error or not? So it turned out that this patient actually had this infusion. Okay, he has a hemorrhagic stroke. So what happens is that the clinician actually infused this mannitol to reduce the intracranial pressure. Usually they will not send a measure osmolality, but in this case they did send. So it was actually quite interesting for us. Okay, so another reason for the clinicians why they want to calculate osmolality is that when they have some diabetes with hyperosmolar hypoglycemic state. So in some very severe diabetes, when glucose concentration is really very high, the glucose, when the kidney pass out the glucose will drag a lot of water along into the urine in osmotic diuresis. So happen you can lose a lot of water, and then the plasma becomes very concentrated. So the plasma osmolality will go 300, 310, 320. Yeah. So clinicians may either send a measure osmolality or maybe try to calculate the osmolality. So you have this case whereby the sodium is 132, urea 11.5, glucose 40. So because my lab, the CRI is up to 40, but if let's say you have raw instrument printout, you can just substitute in the right values. So in this case, it's greater than 315, and our measured osmolality is 325. So they are quite similar. Okay. So what is the relevance to calculated osmolality to technologists on the bench? Because occasionally we see this kind of result. The measured osmolality in this case is actually 420, okay, 420. So it's actually a very interesting result. So 420, you suspect that. Okay. Is it an error? Is it because osmolality measured, we tend to use manual transcription, or then there's usually they may send a PET sample, urine with a serum. So usually when you think about 420 millimole per kg, you think maybe it's a urine sample. Is it a mix up or not? Did I mix up the urine versus the plasma sample, or is it some error in manual entry, or my instrument is inaccurate? So how can we reassure ourselves? So to reassure ourselves, we can use this calculated osmolality calculation, 2 times 155 plus urea 50.1 plus glucose, so 2 times 155 gives you 310, plus 50 gives you 360, plus at least a 40 gives you at least a 400. So in this case, my calculated osmolality is at least a 400, and my measured osmolality is 420. So we are confident we can happily validate the result because both are the same. Yeah, both are similar. So however, as mentioned earlier, in less than 5% of the time, there is actually a real difference. It's not because your sample mix up, it's not because of instrument error, it's not because of transcription error, it's because there's really some ethanol, some ethylene glycol inside the patient plasma, therefore there's a osmolar gap. But for the remaining 95% of the time, actually this calculated osmolality is quite useful to reassure yourself that your measured osmolality is correct. So just now I showed you one of the equation for osmolality, but actually there are at least 37, 38 equations. So generally it's split into two gangs. So number one is like 2 times sodium, 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 and then 2 times sodium again, 2 times sodium plus something, 2 times sodium. And then you also see a 1.86 gang, 1.86 sodium, 1.86 sodium plus something, 1.86 sodium, 1.86 sodium, 1.86 sodium. So why is there split into two? One is 2.0, one is 1.86. So you may wonder why 1.86 is commonly used as a factor. So there's actually this concept of osmotic coefficient. So usually the ions do not dissociate completely. So at about 150 millimole sodium chloride, right, the dissociation is actually 0.93 only. So what happens is that you 0.93 times 2, because you have sodium and chloride, give you 1.86. So that is the reason. But at very dilute concentration, maybe less than 10 millimole or less than 5 millimole, that it will approximate an ideal fluid. Okay, so two formulas that were used just now. The formula that we used, 2 times sodium plus glucose plus urea, actually has a name called the Smith-Line and Gardner, based on this two Dr. Smith-Line and Gardner from 1976. So if anybody asks you what you are using it, I'll say, oh, I'm using the Smith-Line and Gardner formula. Or 8 years later, there's another guy called Bhagat, 1964. So he came out with this. This formula is also quite widely used by because we have limited bandwidth in our brain. I think this is actually more preferred. Yeah, can't remember. This looks very long. Okay, so the take-home messages for the calculated osmolality is that lab we actually do not calculate osmolality. We measure it using freezing point depression. But the osmolar gap, the difference between the measured osmolality and the calculated osmolality can be useful because if there's a gap, it means that there's some osmolyte, maybe it's mannitol, maybe it's ethylene glycol, maybe it's some ethanol, isopropanol. So the relevance to medical technologies on the validation bench is that, let's say you have very weird high plasma osmolality and you're not very confident, you can actually do some calculation. And then let's say they are internally consistent, you can release the result. But sometimes, like 5% of times, it is really because there is supposed to be a gap. So there is actually a difference between the calculated and measured osmolality. Thirdly, we are going to go through this albumin adjusted calcium. So generally, there are two two names. One is albumin adjusted calcium. Okay, the other one is corrected calcium. So some labs report as corrected calcium, but yeah, depends on the. But generally, both are acceptable. So calcium exists in three major fractions. So number one is the free calcium. Free calcium is also known as like the ionized calcium. 50%. They have the protein bound component, 40% to albumin and globulin. Globulin is just the protein minus albumin and fibrinogen. Then remaining 10% is actually complex with citrate, bicarbonate, phosphate. So you have this formula, it's called the pain formula, gives us quite a bit of pain. So corrected calcium or albumin adjusted calcium, whichever way you prefer. Some people more dogmatic, they will prefer that albumin adjusted calcium. Some people are happy with the corrected calcium. So you can see this in a lot of textbook, which is your total calcium plus 0.0240 minus albumin. Okay, and then you may also wonder why what do you call that, why is it over divided by 50? Because 0.02 is equals to 1 over 50. Okay, so both formulas are actually the same, this one and this one. Okay, of note is that if you're looking at some USA thing, albumin, they tend to measure in gram per deciliter, we measure in gram per liter lah, and then calcium we measure in millimole per liter lah. They may measure in mg per deciliter as well. Okay, so what is this whole concept of albumin adjusted calcium is that, let's say you have a total calcium in a patient with normal albumin, you have about 50% is iodized calcium, 40% is our protein bound calcium, and 10% is anions. So in a hypoalbuminic patients, what happens is that you will find that there is actually a little bit of a difference. Where is the difference come from? Okay, the difference is that there is actually a deficit. Why does this deficit comes from? Because okay, if you were to like compare it, okay, so there's actually less albumin. Okay, so basically this albumin has disappeared. So you can see that the protein fraction actually decreases. So what happens is that it causes this apparent deficit. Okay, so in those days whereby you don't have a free calcium, you don't have ionized calcium, when the laboratory just measure total calcium, what happens is that the clinicians, when they interpret it, this guy, although it's low albumin, the free calcium is actually okay, same as this normal albumin guy. But then because the labs only measure total calcium, what happens is that there's this apparent deficit. And because of this apparent deficit, the clinicians may interpret this guy as having low calcium, but it's not, because the physiologically important one is just a free calcium. It's just this free calcium. It's never about this total calcium. Okay, so we are interpret as apparent hypocalcemia. So how do they mitigate this in the past? They decided to say that because there's a deficit, apparent deficit, so we definitely need to do some adjustment. So this is the basis of this adjustment. Okay, so we go back to history again, 1973. So what happens is that Payne did on the x-axis the albumin, the y-axis the calcium. These are, some of them have the abnormal liver function. What happens is that, so they notice that the lower your albumin, the lower your calcium. The higher your albumin, the higher the calcium. And then by measuring this, performing a regression, they can find a slope. So the slope is just in SI unit is 0.02 to 0.025. So therefore, they came out with this equation. So what Payne really wants to mean is that what is the total calcium likely to be if the albumin at 40 gram per liter? So it is just a predictor. So it is like not the absolute truth. Some people think that adjusted albumin concentration, adjusted albumin calcium is the absolute truth, but it's not. It is just based on some regression line, and they say that what is, imagine right now I have a patient with 30 gram per liter of albumin. He has low calcium, and what is the predicted calcium if let's say he has a 40 gram per liter? Yeah, because we are trying to predict it because we are unable to measure the ionized calcium. Yeah, so it's definitely not the absolute truth. And there's a lot of problems with this Payne equation as well. Okay, so which is like in those days, right, the albumin was actually measured using a bromocresol green for albumin. Now half the labs are using bromocresol purple. There's actually some slight differences between green and purple. And then the calcium at the time when Payne was measuring using O-cresolphthalene complexol method. But in general, we find that this adjusted albumin concentration is not very accurate in surgical critically ill patients, people who have very, very low albumin, and patients who have these conditions called primary hyperparathyroidism, whereby the surgeons, whereby they have some parathyroid gland and then they have a bit of adenoma. So the surgeons will tend to ask for ionized calcium instead of just relying on the total calcium and the adjusted albumin calcium. So the problem is that different labs actually have different equations, and sometimes it's quite hard to interpret. So we look at this. This is another patient of mine. So he was admitted to a hospital in a central hospital, and he saw me at clinic subsequently. So the albumin was 38, was within reference limit. The calcium was 2.43, also within reference limit. But the adjusted calcium is above high limit. Why is that so? So we try to use the pain equation. Okay, so total calcium plus 0.02, 40 minus albumin give me 2.47. My pain equation gives 2.47, but it's 2.52. How come? So this lab is 2.52. So because actually the albumin range is different, so 38 to 48. So they might have used 43 as the midpoint of their albumin reference range. So if you were to use 43 as midpoint, you get 2.53. So I think the some differences is actually due to the rounding off. So because different labs use different methods for both calcium and albumin, we have this ACB, UK, Association of Clinical Biochemistry and Laboratory Medicine in the United Kingdom. So in 2015, they published an albumin-adjusted calcium proposition paper that encourages lab to derive their own equations. How do you derive their own equations? So basically, you need collect 1,000 data points of patients, of people. And then these 1,000 calcium values and albumin values, right, should span at least 30 albumin values. It means that 30 means maybe your albumin is 25 gram per liter, 26, 27, 28, 29, all the way up to 55 gram per liter. So 25 to 30 to 55 or 20 to 50 gram per liter. And actually, it's quite difficult to collect such a big patients. I mean, with 30, with over a spread of such a big albumin from 20 to 50. So you also need to exclude patients whereby there are other conditions such as like kidney disease, such as hyperparathyroidism. Okay, and then we also need to exclude people with cancer or vitamin D deficiency. Okay, so these are some of the criteria. You all can Google the ACB position guideline, and then if you are interested to develop equations for your lab. Okay, so in general, what they do is they just plot calcium on y-axis, albumin on x-axis, and then you find the slope of the best fit regression line and intercept, and then you just substitute your slope and your intercept inside, and then you can find your adjusted calcium. Okay, so as we mentioned just now, what happens is that albumin adjusted calcium is just to have an adjustment for this apparent deficit so that we can interpret our total calcium better, but it's not really the absolute truth. Okay, so sometimes we actually have a three-way battle between total calcium, adjusted calcium, and ionized calcium, and sometimes we can disagree with each other, as we have shown just now in my patient case. So how's the performance of this albumin adjusted calcium? Actually, in ICU patients, in critically ill patients, is really terrible. So compared to ionized calcium, adjusted calcium only agrees in 55%, maybe to 65%. In fact, your total calcium, that means the one that you throw away the pain equation, you don't do any adjustment, actually is better. It categorizes patients better. So of course, this is a bio cohort because these are actually very sick patients, ICU patients, ED patients, yeah. But for the general well-being patients, right? Well patients, maybe it's more accurate. But for these acutely sick patients, adjusted calcium may not be a very good idea. Okay, this is because our albumin adjusted calcium, as the name suggests, only accounts for albumin. It doesn't account for other factors. There are other factors, other abnormal proteins, other free fatty acids that actually may disrupt this ionized calcium. Okay, so in summary, the use of albumin adjusted calcium is common. As laboratory, I think that we still need to provide them with total calcium and albumin adjusted calcium because a lot of clinicians still uses it. But it's good to know the limitations. The most common cited is actually the pain equation. Okay, so the UK ACB has provided guidance for us on how to calculate our own lab-specific albumin adjusted formula. But we must know that in our critical patients, in ICU patients, the albumin adjusted calcium is actually suboptimal. In fact, total calcium, the one that's uncorrected, unadjusted, is actually better than this adjustment. And lastly, we are going to go through glomerular filtration rate. So this part is a little bit newer, especially for the race correction in 2021. And okay, so glomerular filtration rate is actually something that's not very easy to explain. But what happens is that you imagine that you can see this picture. This picture is a nephron which I took from Wikipedia. So okay, so 1 million of this thing times 1 million will give you a left kidney. 1 million times this will give you a right kidney. So each kidney have about 1 million of it. What happens is that you have blood okay, that's coming in, okay, and then goes to this things called glomerulus, and then there's actually this filter over here, and this will try to filter inside this nephron, these renal tubules, and then eventually will pass out as urine. So what happens is that you can also think of it as a glomerular filtration rate as a, let's say you have a funnel. You also have a filter paper. Let's say you have a filter paper. It's a very ugly drawing of the filter paper. And then, okay, so if, let's say you pour some water, okay, and then what happens is that the water will slowly flow up. Yeah, so every minute there will be some ml of water, 1,000 ml of plasma flowing out. So what happens is that the glomerulus is like this filter paper. So we call it the glomerular filtration rate. How well this filter paper, how well the glomerulus altogether, the 1 million of them on the left and 1 million on the right can filter our blood. So what happens is that the important proteins are all kept inside this filter paper. The waste products are being filtered away. So this is called the glomerular filtration rate. Okay, so the units will be ml per minute as I've shown. Okay, sometimes it can actually be corrected from this body surface area, and we see this 1.73 meters square. And so we use creatine as a surrogate. So what happens is that you can, number one is actually what I call filtration. So ideally, the marker will be just filtered. It doesn't get reabsorbed back to the blood, and it doesn't get secreted back to the nephron. So, but this will be an ideal marker. Okay, so there are some ideal markers such as inulin, which is a polysaccharide. Okay, so what happens is that in experiments, in physiological studies, okay, infuse inulin inside the patient bloodstream. And then after that, after several hours, we measure the inulin levels in the bloodstream, and then we also measure the inulin levels in the urine. Okay, so there are also other methods. Let's say, for example, you are a kidney donor. Yeah, because we have 2 kidneys, and there are some conditions whereby like our relatives have some kidney failures, and we might be a suitable donor. So we might before donating a kidney, what the nephrologist will insist on is to measure the GFR. So what happens is that they will actually infuse some of these chemicals, and then to get a very accurate measurement of what is our glomerular filtration rate, because after the kidney transplant, the kidney function will be reduced. So they need to have a very good baseline. Okay, but it's very tedious. So because you need to infuse a additional marker. So in life, we always try to take shortcut, and in 30 years ago, 40 years ago, then you realize that actually you can take this shortcut. It's called the creatinine shortcut. So instead of infusing it, we just measure 24 hours urine collection plus serum creatinine, and we call it creatinine clearance. So I believe a lot of laboratories are still doing today. The nephrologist, the renal physician, they are still sending this 24 hours urinary creatinine with the serum creatinine to us. Okay, but as I mentioned just now, creatinine is not a perfect marker because after it gets filtered, you get reabsorbed, and then you also get secreted. So it's not just direct filter. So it doesn't fully measure the glomerular filtration rate. So, but then this shortcut is also not short enough because we still need to measure the urine. We still need to collect a 24 hours urine sample. Is there a simpler way? So yes. So you're going to take the shortest of the shortcut, which is just use a single serum of plasma creatinine, and then you try to deduce the estimated, the glomerular filtration rate of the creatinine clearance. So what happens is that just by doing a study, maybe you take 1,000 patients, you measure the GFR or you measure the CRCL, and then you compare with this baseline serum creatinine, and then you can derive some equations. So, but before that, we can go through what is creatinine. So creatinine is actually comes from this thing called creatine. So in our muscles, there's this thing called creatine phosphate. Creatine phosphate is used as an energy source to convert the ADP to ATP quickly. So, but then every day there will be some percentage of it get dehydrated and cyclize it, becomes a creatinine as a waste product. So if let's say you are consuming a lot of meat, you have higher muscle mass, you actually can have higher creatinine. And then certain race with bigger builds might also have greater creatinine as well. And let's say you go to some of the health supplement stores, your rugby players, you want to buy creatine for your workout, your muscle workout. Okay, you buy creatine, and then you can get higher serum creatinine as well. And then some drugs will actually cause inhibit the secretion of the creatinine, causing higher creatinine. And about the early 2000s, there's actually change in the creatinine assays calibration to an IDMS traceable assay. So what are the equations available? So what happens is that 1976, sorry, I'm doing that. There's this guy called Cockgrove and Henry Gotts. So they are from Canada. So they studied 249 men, okay, so with creatinine clearance. Their reference method is just the 24 hours urine creatinine clearance. That means they send a urine sample, 24 hours urine sample, and then with a serum creatinine. And based on they calculate the creatinine clearance, and then based on that single creatinine, they come out with this equation. So what's the problem with this equation? They didn't even use any female. They just see that if females, they are proteinal build. So I just give a 15% discount. So times 0.85. Yeah. So but then their original study, they didn't have any females. So but it was 1976. So in the 80s, 90s, there's a lot of drugs. And what happens is that till today, this is actually very used widely by the pharmacists. So this is actually an example of my hospital empiric antimicrobial guidelines. So you can see that depending on the creatinine clearance calculated by Cockgrove, you can have different antibiotic dose. So let's say your creatinine clearance is greater than 50 ml per minute, you give this IV cafazolin 2 grams every 8 hourly. But let's say it's less than 10 ml, you just give 1 gram 24 hourly. It's let's say 10 to 30. So basically, this Cockgrove is used for the pharmacists to dose the antibiotics. Okay, and then 1976 and then 1999, you have another guy which is called Professor Andrew Levy. Okay, so he decided to study 1,628 patients. So the reference method this time around is actually the one that is measured. So it's the one that you have to inject in their veins, and then they have to collect in the urine, and then also collect in their blood. It's radioactive. So they come out with this formula as a correction factor for female, and also a correction factor for African American. But their studies did include African American and females. Okay. In about 2005 and 26, because there's actually the change in the serum creatinine calibration, we change from the non-IDMS to IDMS. So what happens is that the serum creatinine values generally fall. So when you have a lower serum creatinine value to the power of a negative value, when you have smaller value to power negative value, you get a bigger value. So you get a bigger value. So therefore, you need to correct it with a smaller value. So therefore, 186 becomes 175. I believe as of today, a number of labs are still using this thing called the MDRD equation. Okay, fast forward another 13 years. I mean, fast forward another 10 years. Okay, CKD EPI. So also the same guy. Okay, so Professor Andrew Levy from Tufts University, calling disease epidemiology collaboration. So he found out that, okay, based on this is 8,000 plus, the reference method is still the same, is the measured GFR from iodotalamide. Okay, so they found out that this is the equation to use, but you may think that this is a very, very complicated equation. So we'll go through an example. So this equation looks very complicated. Okay, so consider a Malay woman. That doesn't have to be Malay. It can be Chinese, can be Indian, can be Filipino, can be Burmese, can be Korean, can be Japanese, can be Caucasian, can be Russian. So as long as it's non-black, we don't. As long as it's non-black, the formula is actually the same. So how do we calculate this? So you have got this. So firstly, we have this because we can change it because the equation I'm using is directly based on their published formula. So they use mg per deciliter. So we also have to change it to mg per deciliter. Okay, so 56 micromole times 0.011312 gives you this 0.6347, and then you have this thing which is serum creatinine over K. So K for females is 0.7. So we just need to use the mg per deciliter divided by 0.7 gives you 0.904. Okay, and then we look at this because because this thing like the minimum SK over 1 alpha is very, very complicated. So actually it's not very complicated. So basically minimum just means you have two values, 0.90 and 1. which one is smaller? So of course 0.9 is smaller than 1, so I choose 0.9. 0.9 to the power of negative number, I give you 1.03. Okay, and then you have this max. So SCR over K. So once again, which one is bigger, or 0.9 is bigger? So max means the bigger one. So we choose the one which is bigger. So 1 to the power of any number give you 1 as well. And then lastly, we have this H. So 0.993, because it's 39 years old to the power, we give 0.76. And then we multiply everything together because it's premier, so 1.018. And then because it's actually a non-black, so therefore we don't need to give 1 times 1.157. So we can report this round up. I mean, round to the nearest whole number, report this as 113 ml per minute per 1.73 meters square. So you may also wonder, like, what's the performance between the CKD, EPI, and MDRD? So okay, so this is on the x-axis is the estimated, on the y-axis is the difference between the measured and the estimated. So closest to 0 is the best, because it shows that there's actually no difference. Okay, then this is the median. Okay, the median line. So you can see that actually CKD, EPI, the performance is slightly better than the MDRD, but the spread is actually quite wide. And NDRD at about 60, what happens is that, like, it starts to actually underestimates. So therefore, some laboratory actually don't report. Let's say you get a greater than 60 ml per minute per 1.73 meters square, you just report as greater than 60. It won't give you the exact. Whereas for CKD, EPI, you can go all the way up to 120 and beyond. So you may also wonder, like, GFR being reported as 1.73 meters square. So what is 1.73 meters square? So it's actually this thing called a standardized body surface area. So it's based on 1920s. There's actually this American size. So it corresponds to, like, the height is 172 cm, 62 kg, or 17 cm, 64 kg. So you can estimate your own body surface area by several formulas. The easiest would be height. Let's say you are 160 cm, then your height is your weight is 50 kg. 160 times 50 divided by 3,600. Then you coding square root, so everybody can take out a calculator and calculate. So it's used mainly for the chemotherapy dosing, and it's quite a useful anthropometric measures. So lastly, we also think about cystatin C. So actually, cystatin C equation by itself is actually not very useful. So 1 minus P30 means P30 means people with the difference between MGFR and the estimated, that means less than 30%. Less than 30% difference between the measured one. So 1 minus P30 is the proportion of greater than 30% difference. So the lower the better. So you can see the green line is actually quite high. That means it's quite inaccurate. So generally, just with a cystatin C itself, is actually the performance is not very good as compared to creatine equations. So current Singapore labs, most of us are actually using CKD API. Some labs are still using the MDRD. Because generally our clientele is actually the local population, Malay, Chinese, Indian. So usually we are not particular with the race, so we won't really in our LIS configure as a black race, therefore you times 1.157. Okay, Cockroach got just like I shown, pharmacists love it, but lab usually cannot provide it because LIS we don't really have the information of the weight. But I know of at least one laboratory who actually provides electronic order, which they specifically mentioned that please key in the weight. So this is actually quite new because of the Black Lives Movement in the past 2 years. And actually in the past 2 years, there's actually a lot of focus on should we have this race correction for African Americans. So what happens is that over the past 2-3 years, they actually increasingly realize that the African Americans are actually not getting the renal care that they are as compared to the whites. So the African Americans actually may actually have a decline in the glomerular filtration rate at an earlier age and faster, and then they have actually more incidents of kidney disease. But they are less likely to have dialysis therapy, and then they are also not likely to be waitlisted for kidney transplant. And they find that the problem is actually because we give automatic bonus 16% for blacks. So because you can see that this is a times 1.157, so if you are of black race, you identify as a black race, you immediately will get a 16% bonus. And sometimes bonus in terms of money is good, but in terms of GFR may not be good, because what happens is that, let's say for non-black, for white, for Hispanic, okay, so for Asian, so let's say your GFR is 60, let's say you get a 16% bonus, becomes 70. So 75 become 87, 45 become 52. So what happens is that the doctor will think that this guy, the kidney function is very good. So they are unlikely to refer them to specialist care, or they are unlikely to give them certain medications that to help with their kidney function. They are unlikely to control their blood pressure more tightly. So whenever you have a justification for certain race, you want to have a certain modifier, then you might need to really think about, like, do you get the equality of care or not? So in this case, over the past 2-3 years, I mean, the Americans, they recognize that actually when you give a black correction for that, you may actually worsen the care. So it's not equal. So last month, they actually have the NKF, not the Singapore NKF, but the American National Kidney Foundation and the Association of the American Society for Nephrologists released a new statement that they say that, okay, we need to have a refit equation without the race variable. So must immediately implement in all laboratories in the US. But of course, they are the nephrologists on AACC forum side. Okay, the laboratories may not really comply, and there's actually a heated discussion whether should we follow what the nephrologist says? Should we just remove the race? Should we change the equation or not? So this is the current one, the 2009 CKD EPI. Essentially, it's almost the same. Okay, and sometimes what happens is that you actually don't have you want to correct it, you don't want to times the 16% bonus, but in this case actually they refitted the whole equations. So it remains to be seen whether Singapore labs need to refit the equations or not. But what it means is that this is for black adults, this is for non-black adults. So this is the original CKD EPI so this is overestimate. So basically original CKD EPI overestimate the median by 3.7. For non-blacks is 0.5. This is the refit. It underestimate that by 2.6. Sometimes underestimation is actually a good thing, because underestimate means that people think that your kidney problem is actually more serious than it is. They give you earlier intervention. Whereas the new equation for the non-blacks actually the overestimate. So just look at the non-blacks itself, is actually worse. The performance is actually worse, and this is the 1 minus P30. Essentially, last time was 15% inaccuracy versus 11% for the non-blacks, and then now if you have inaccuracy is about 13% for the refitted for blacks, whereas 14%. So it makes the things more equal between blacks and non-blacks. Okay. So the take-home messages is that many equations stood the test of time. We have the Frediswell, 1972, 50 years already. Many things cannot last for 50 years. No change is very difficult, but Frediswell, we are still using it. I believe we are going to continue to use it at least for the next 10 to 20 years. Smithline and Gardner, the calculated osmolality. Crocodile, the pharmacy are still using it, the plain equation for the albumin adjusted calcium. So calculated values have underlying physiological assumptions, and so if these assumptions, if they are breached, then the performance will suffer. But sometimes the assumptions are breached, so you know that the osmolar gap in toxicology. So if we see a osmolar gap, we know that, okay, this guy is probably having like some ethylene glycol, some mannitol, some ethanol, some toxic substances. In other cases, right, so discordance will cause clinical confusion. So for example, adjusted calcium, if let's say the clinician thinks that it's really the truth and the only truth, and he will be very confused how come the adjusted calcium and the ionized calcium are different. And then of course, lastly, because the Americans, they are starting to refit their CKD EPI equation to the 2021 without the black race correction, does Singapore has to follow suit? But of course, it will actually depend on your clientele. So if let's say you are, especially COVID now is going to end soon, medical tourism is going to come back. So let's say you have your laboratory serve a lot of medical tourists from Africa, you have African statesmen that are coming in, and then because the American labs are refitting their equations, so you have to follow suit as well. But if let's say you are just based on the Singapore population, the local population itself, then maybe you can continue on the CKD 2009. Okay, thank you everybody for your time. I think we come to the end of the presentation. Thank you. Hello, hi CD. So is there any questions?
Oh, sorry, I was muted. Okay, thank you, Dr. Tan, for the enlightening presentation. There's a lot of calculations that we see. So let's move to Q&A. We got a few questions here. The first question, there are times where LDL cannot be measured or calculated. What is the best way to explain to clinic staff about it?
Okay, so the LDL cannot be calculated is because it exceeds the TG of 4.5 lah. So in this case, we just need to tell the clinic that okay, because the formula based on this Freddy's well, if I can send her a paper if they really wish, just say that TG greater than 4.5 millimole per liter, this equation is invalid. You will get negative LDL. This is just the limitations. So what we can do is that we can suggest that we ask the patient to fast, or we can measure a direct LDL instead.
Thank
But
you, Dr.
it's a
Tan.
common thing.
Okay, next question number 2. What is your recommendation on cases having calcium value fall into critical range? However, the corrected calcium is not in critical range.
Okay, so in that case, right, because personally lah, okay, my view is that corrected calcium is not very accurate. So I will still inform the doctor that there is a critical result for the total calcium, and then we let them decide clinically. Yeah, because sometimes sometimes what happens is that because let's say your albumin is actually at 45, what slightly higher albumin, the correction actually can be a bit weird as well. So what I suggest is that we just still need to critically inform the doctor, and then depending on the clinical need, maybe we want to send an ionized calcium.
So question number 3. Is there a method of estimating potassium level when the blood is completely lysed? Because some of the doctors will insist, okay, that's new for me.
So,
because some of the doctors will insist the lab to release the level of potassium, and they claim they can estimate the potassium level with the lysed serum potassium level.
Yes. So actually, this is something which I'm really very interested in as well lah. So like nowadays, most of our labs we have a hemolysis index, so a H index. So some of the H index is measured in mg per deciliter. So I think the Roche one does it. I think the Apple is also at mg per deciliter, but some other labs give you plus. But let's say 3+ and 4+ will correspond to a certain mg per deciliters of hemoglobin. So based on this mg per deciliter, because just earlier on I've shown you like a lot of the MCHC equations and everything, right? So generally we can derive a formula based on the hemolysis index. So I can tell you there are actually some publications already. So for every 100 mg per deciliter, the potassium will rise by about 0.5. But it varies from paper to paper. Some is 0.6, some is 0.7. So basically, maybe the raw value is 300 mg per deciliter of hemolysis index. 300 mg is 0.3 gram per deciliter. So 300, because 100 is 0.5, so 300 is 1.5. So they are corrected formulas. But how accurate this corrected formula is it varies a bit. So you must tell them that this one is not 100% accurate. There's also this possibility of what I call that intravascular hemolysis. So intravascular hemolysis, this equation will not hold already. Only the exogenous one, your phlebotomy too tightly or something like this. But for my lab, we adopt a very liberal approach. So even if grossly homolyzed, we still release the potassium because what happens is that let's say it's grossly hemolyzed, and then let's say the potassium is 3.4. We know that this guy is actually low potassium, likely to be low potassium.
Okay. Next question. Can I say that the main difference between the 3 EGFR calculations is due to use of factors for race, gender, height, and weight? Is there a reason why labs are still offering other equations when CKD EPI seems to be the most ideal?
Okay, so the Cockroach God, right? So 1976, so when the pharmacists are studying, right, and then when the medical students studying, right, so they always somehow the curriculum is always about Cockroach God. So this was the first equation that they learned because 1976, the professors are also 1976, so they really believe in that. So so because in terms of dosing, in terms of this medication, they really love the glucagon a lot. So that's for the pharmacy dosing because of the history behind it. Because all the studies were done in the 80s and the early 90s, so it was based on the glucagon. So they believe in that. But moving on, right now we have MDRD and CKD EPI lah. So 1999 MDRD, 2006 we also have this MDRD with this IDMS creatinine. By 2009 is this CKD EPI already. So I think most Singapore labs, right, are generally towards the CKD EPI lah, because it's slightly more accurate than MDRD and you can report more than 60 ml per minute lah. I would feel that for lab wise, because we do not know the weight of the patient, I think that if possible, we should standardize using at least the CKD EPI 2009 lah. But of course, now the next question is you have this 2021 refit equation that's affecting America now, and very soon our renal physician is going to attend the American conferences, and you're going to say that, hey, Jungo and I just attended this American Society of Nephrology, and they are going to refit. Is your lab going to refit as well? So we'll be influenced by them lah. Yeah. Yeah, but I agree with you. CKD EPI 2009, if let's say your lab is suffering it, I think that should be the way, at least for now.
Okay. How do you explain to clinicians if there is a difference between calculated and measured LDL?
Oh, so I think so once again we can show them the paper of this Freddy-Swell formula and say that, okay, to try and test the equations for 50 years. In fact, then you can also try to tell them that actually all your old studies, your Framingham heart studies, that show that LDL cholesterol is the one that causes the arteriosclerosis and reduced mortality. They are all using this Freddy-Swell formula. So so this formula is actually still valid. So you can show them the equation itself, and then you can say that, hey, but now technology has improved already. 50 years has passed, so now my lab got this measured LDL value. You can just measure the LDL. Of course, there will be some differences, but you're just interested in LDL. I give you some lobang. I charge you in a very fair price. Yeah, so you can just send this measured LDL to us. Yeah, so no, it's a state of the art. Okay, just tell them that it's a state of the art. Now everybody is measuring LDL. So yeah, so a few ways, but I think both are okay. So it depends on what your lab offers lah. Both in my opinion is good. Yeah.
Okay, next, could you mention a little about anion gap? What are some points to note? Example, if the anion gap, if the anion gap is less than 10.
Okay, so anion gap. Okay, so anion gap, as mentioned, right? So you have the positive ions, which is your potassium and sodium, mainly sodium and some potassium. You have your anions, which is your bicarbonate and chloride. Okay, so you minus the positive ions from the negative ions. That means sodium plus potassium minus chloride minus bicarbonate will give you an anion gap. Some labs don't put the potassium, but the reference range without the potassium is about maybe 4 to 12, with potassium maybe 8 to 16 kind. So if let's say the anion gap, right, is very, sorry, is high or low? Is low or sorry, what the question? Low lah. So if the
yes,
anion gap is low, it means actually is perfectly fine. Yeah, it's only in high anion gap and the low bicarbonate that we are worried on. But let's say if there's very low anion gap, one of the reasons could be that the reason is actually because the albumin is actually low. Because yeah, so what happens is that the albumin actually, right, is actually the negative anions. Yeah, so what happens, let's say you actually have low albumin, you can actually have a smaller anion gap. Yeah, so that's one of the causes. But generally, we are not that worried about low anion gap. But let's say also because you need to also look at the what I call normal anion gap metabolic acidosis. So in normal anion gap metabolic acidosis is actually what happens is that the bicarbonate is slightly low, but the chloride is compensated for it. So it actually means that there's actually a loss in the bicarbonate. So we just need to work out why is there a bicarbonate loss. Maybe it's because through diarrhea, maybe it's because it's taking some medications. There's really some renal tubular acidosis, losing bicarbonate. Yeah.
Okay. Next question, does it need fasting for LDL measured assay?
Okay, so generally the idea is that you do not need fasting for magic LDL assay lah. In fact, for calculated ones, you actually don't need the fasting lah. In fact, there was a 2018 guidelines lah by the Dr. Lo Ziping. So it was actually approved by the ministry as well lah. So it says it's actually non-fasting lipid panel lah. So yeah, so in that guideline, they also say that actually you can just use HbA1c for screening as well. So the rationale is that even if, let's say, for example, a patient has a breakfast, maybe 8 o'clock, 9 o'clock, so comes to the lab maybe at 11 o'clock, the 2-3 hours, actually the triglycerides, it's not going to be that high. Yeah, so you still can calculate it. In fact, other countries such as like Denmark in the Europe, right? Even for calculated LDL, they are saying that you don't need fasting. Yeah, then definitely magic LDL don't need fasting as well.
Okay. Wow. Today we have a lot of questions for you. Let's do the last one.
No problem.
Yeah, let's do the last one. With the limitations in LDL calculation, why do labs not offer direct LDL routinely?
Okay, so once again, I think this assay comes relatively newer than a lot of other assays lah. So sometimes it maybe because of the certain pricing lah, and then because actually LDL calculated by calculation, we can still charge our requester. So because actually although we never measure the thing, we calculate the thing, because calculation takes LIS resources, it takes computational power, so we can actually charge them for it. So I think maybe one of the reasons, I'm not sure is that because let's say because you are charging people for HDL, TG, and then total cholesterol, then you must not charge them for calculated LDL, but you don't need any reagent price for it. So that's one of the reasons. Another reason is actually it's very tried and tested lah. And then at the starting, people were actually quite concerned about the direct LDL, whether it's accurate. But I think it has been around 10 years plus already. So I think it's fine. Yeah.
Okay, I think just one last one. Okay. I mean, we were talking about calculated values, and then yeah, you did mention that some labs offer measured, some don't offer the calculated, and then some report anion gap, some don't. Do you think there should actually be harmonization, in your opinion, between the PHIs?
My one opinion is that okay, so okay, yeah, so I think that will be very different from the society opinion lah. So okay, so okay, so because I think for the public labs, you are moving towards this thing called the NGEM lah. So it's next generation electronic medical records lah. So which all the public labs will standardize even in the ordering panel. So it becomes a top-down approach. You are sort of being constrained by it, we cannot come out with our own panel lah. So there might be some limitations because of this NGEMR lah. So the advantages is that like clinicians, when they rotate from one places to another places, or patients go from one place to another places, they will see their lab report very similarly lah. So there won't be any confusion lah. So that is the advantage lah. But then for the more conservative, the more old school, so I feel that sometimes I'm a bit more old school. You feel that actually like labs should have the autonomy, because sometimes you want to discuss with your own clinicians, I want to discuss with your own different laboratory actually have different contexts. So we want to design certain panels to fit our hospital, to see our patient profile. So it is also good to have some liberty for us, like instead of standardization for everything lah. So I mean that our salaries are also not standardized, right? Yeah. So that's actually from one of the senior professors, which I asked what is his opinion about this kind of standardization. Since actually no, our salaries are also not standardized, so no need standardized. But this is the more conservative and the more old school opinion lah. There are advantages lah. There are advantages of holding harmonization. You harmonize the reference range, the SOP or harmonize, but also realistically speaking, like let's say you go to like let's say I'm going to a certain hospital A, I tend to have my follow up at that hospital A also, so I may not really jump around lah. So the idea that you will jump around may not necessarily be true also, but I think the trend is to actually to harmonize and everything. Yeah. Okay, there are no more questions.
Yeah, I think that's all we have for today, and we will now close the session. Thank you, Dr. Tan, for the enlightening presentation, and thank you to all our audience for staying throughout. It's already 7:45. So
Thank you.
thank you for your attention, and
Thank you.
I wish all of you a very good evening. Thank you.
Thank you, Cindy. Thank you. Thank you. Thank you. Thank you all the participants. Yeah, thank you.